Okay, Assalamu alaikum everyone. I hope you're all doing well. So today inshallah we'll be talking about a very important topic, which is infective endocarditis. And inshallah we'll be trying to summarize everything in about 4 slides. Okay, so we'll go through three main things. First of all, for infective endocarditis, we'll be going through prophylaxis, first thing. Second thing is we'll be going through the empirical treatment. What do we mean by empirical treatment? Is once we know that the patient has an infection, infective endocarditis, but we're not sure about the organism, the microorganism that's causing this infection. In this case, while we're waiting for laboratory tests to tell us which species it is, or which bacteria specifically, for example, it is, we would give them a wide spectrum treatment, pharmacological treatment, to try to cover everything. As so long that we don't have the laboratory tests, we would do that. As soon as we get the laboratory tests, we would switch into the third thing, which is going to be definitive treatment. So we'll give them the treatment for this specific microorganism. Okay? So, before we move on to medication, we need to talk about prophylaxis and when we give prophylaxis, because this is very important. And it has been changing in the last couple of years based on researches that have been emerging. So, right here, for prophylaxis, think of it as prophylaxis, 2 branches. People who are at high risk of developing infective endocarditis and are recommended to have prophylaxis. That's one. The other branch is when we would give them prophylaxis. Actually, we're not going to give them prophylaxis the whole day or 24/7. We're going to give them prophylaxis in specific scenarios. So we'll talk about the people and the scenarios. 2 branches. We'll first start with the first branch, which is the people. Who do I give prophylaxis? Only for patients at high risk of infective endocarditis, who are patients with prosthetic valve or prosthetic material used for cardiac valve repair. So if a patient has a prosthetic valve, they are considered a high-risk patient for developing infective endocarditis, and we would give them prophylaxis. Likewise with the rest. Who are the rest? People who already had infective endocarditis before. So previous infective endocarditis patients and patients with congenital heart diseases. Okay, so far so good. So 3. So now that's the first branch. Second branch is when we would give them, which is right here. We would be giving them the prophylaxis in 3 cases and the special 4th case. Okay? So what are the 3 cases? It would be in dental procedures, not all dental procedures, but only those 3 mentioned here. Okay? What are those 3? For dental procedures requiring manipulation of the gingival or periapical region of the teeth or perforation of the oral mucosa. Okay? So those are regions in the teeth, and this is perforation or laceration of the oral mucosa. Okay? Okay. Other than that, you would see not recommended, not recommended, not recommended, not recommended. However, for example, let's say, and this is for the special case I was talking to you about. Let's say the patient comes and they're going to have a GIT procedure, for example, okay? And we figured out that this patient has an infection at this site, okay? In this case, we would give prophylaxis. Why would we give prophylaxis in this case if we're going to do a procedure and there is already an infection, okay, in the site, or we find an infection? The reason is because we have 2 reasons. There are 2 reasons. First is to treat the site. To treat the site of infection, we would give the antibiotic to go and treat the site of infection. Okay, so this is one useful feature of prophylaxis in this case. Second useful feature would be to give prophylaxis for infective endocarditis. They already have an infection. It might lead to infective endocarditis. So we would give prophylaxis as well. Okay? So prophylaxis is giving you two effects in this case. Okay? So now we're done with the two branches on who to give prophylaxis to and when to give the prophylaxis to them. Okay? To those people. Now, this is very important, and before we move on to the types of treatments like prophylaxis and empirical treatment and all the pharmacological drugs, we'll discuss some rules, okay? And those are very important rules. Tamam? We have 4 rules. First of which is the vancomycin rule, okay? I called it the vancomycin rule. Yeah, it's not really called vancomycin rule, but it's the vancomycin rule, okay? What does it say? It says that vancomycin is always and only given for patients or in 3 situations. Okay? We give them if the species that infected the person and they developed infective endocarditis, if that species is beta-lactam resistant species. Okay? So beta-lactam, like for example penicillin, amoxicillin, okay? So any species that's resistant to those medications, the beta-lactams, we would give vancomycin, okay? If the patient, second scenario now, if the patient has beta-lactam allergy, again, we would give vancomycin, okay? And in the third scenario, if if there's a native valve endocarditis, okay? Native valve endocarditis, however, it's nosocomial, meaning it was acquired, the infection was acquired in like a hospital, for example, okay? Hospital acquired infection. And we'll say why it's, specifically we say hospital acquired, we should give vancomycin, which is a very strong antibiotic, by the way, and we'll get to this right now. So nosocomial native valve endocarditis, or if they have a prosthetic valve endocarditis less than 12 months ago. Why specifically less than 12 months ago? Why not after 12 months? The reason is as follows. Prosthetic valves, after about 12 months, the endocardium, we have 3 layers of the heart, the endocardium, the most inner layer, it would cover it, totally cover the prosthetic valve, okay? The valve we implanted in the heart, it would totally cover it, making it just like the native, because it's now covered by the endocardium, okay? An analogy that we can use is like a person coming into our university, for example, and they're still new and we're not really, we don't really know him, they don't really have friends at the beginning. However, after a certain amount of time, we consider them what? A part of our university, khalas. They're a student university. At the beginning, we're like, this is the new student. Now, he or she, they're one of us now. You get me? So this is what happens here, okay? And this is why we would give it in this case. Because if it's before 12 months, we would consider it prosthetic valve, and it would be still, it would still be, it wouldn't be considered native, okay? So this is the reason. And for vancomycin, why do we give vancomycin only in these cases? Only in these 3 cases, for this lecture at least. Why in these cases? The reason is vancomycin is a very strong medication that we would give, or antibiotic. And it works against very virulent means strong, okay? Strong microorganisms. We would give it in this case only for those cases because of the virulent species, or for example, if the patient has like an allergy to penicillin, like beta-lactam, beta-lactams overall, so we can't give them beta-lactams, okay? The reason is vancomycin, especially recently, the resistance for it has been increasing because people have been using it just like this. Because they're like, okay, vancomycin is very strong, I'll just give it for all species, weak or strong, and it would work. That's true, it would work. However, if we keep giving it, eventually there will be resistance towards it. Okay? The bacteria and all of those microorganisms, they will develop resistance to it. But then when we try to use it, it won't work. and we don't really have many other options other than vancomycin for treating such strong species. This is why we try to reserve it only if we need it. You get me? It's like you have a very special weapon, you only use it when you need it. Else the ammo will finish. Or the enemies, they will develop protection against it because they learn the weapon. This is what happens. Okay? So this is for the first rule. Second rule is gentamicin. We'll go through it quickly. Gentamicin, when we would give it, or why would we give it? Two reasons. It shortens the treatment period, that's one. Two, it has a synergistic effect with two medications, beta-lactams, or one class of medication, beta-lactams, and vancomycin. Okay? Okay. And here, for rifampicin, very important medication, and as soon as you see rifampicin equal prosthetic valve. Rifampicin equal prosthetic valve. This is the rule. Rifampicin equal prosthetic valve. Only and always for prosthetic valves. To be specific, not any prosthetic valve. As we said, the new students, if they come in and after some period of time, they will be considered one of us in the university. Same thing with the prosthetic valve as we mentioned. So it's only before 12 months. Before 12 months, before the endocardium totally covers the prosthetic valve. So we would still consider it foreign in this case, because the endocardium hasn't covered it fully, it's still exposed. And that means the patient is in high risk of developing infective endocarditis. So this is why we give rifampicin specifically for patients who have a prosthetic valve less than 12 months ago. Okay? And then we have the last rule, the fourth rule, which is fluxicillin. Fluxicillin equals staph species. Okay? So staphylococci for treatment of staphylococci. Okay? So those are the four rules that we'll be following throughout those two slides, and then that's it. Okay? So as promised, it will be 4 slides. معلش طولت عليكم شوي بس. The rules are very important because sometimes in the MCQ there might be weird combinations of certain medications that perhaps aren't here or aren't exactly similar to this, but you will be able to deduce the answer from those rules. تمام? Okay. So we'll start with prophylaxis. And we'll go through this quickly, inshallah. So prophylaxis, we don't use vancomycin here, okay? Because again, vancomycin reserved only for when we really need it, okay? So if patient is not allergic to penicillin, then give them penicillin. Give them penicillin, amoxicillin, ceftriaxone as well. You can give them ceftriaxone, works. But if they're allergic to penicillin, remove penicillins or beta-lactams overall, by the way. Remove beta-lactams, including penicillin, amoxicillin, remove them, and add cephalexin, macrolides, okay? We can give macrolides, tetracyclines like doxycycline, and this is or. You would give them only one of those. Or ceftriaxone, cefazolin, we'd give them those, okay? Okay. So this is for prophylaxis. We're done with prophylaxis. Now for the empirical treatment. As we said, empirical treatment, broad spectrum treatment. We don't know the species, so we give them treatment for everything, hoping that it would target the species until we get the blood tests and we know which species to target. Tamam? Tamam. Okay. Firstly, we have if the patient comes with, or the infection is community acquired, so not nosocomial, not hospital, so it's not strong, we don't expect it to be strong, it's usually weaker. Community acquired native valve, or after 12 months of prosthetic valve. Why after 12 months? Because now it will be considered what? Not foreign, it will be considered native. Okay? What we would give, now it will be plus here, not or plus, because again, wide spectrum. We would give amoxicillin, ceftriaxone, or fluxicillin if we're suspecting anti-staph, as we said, this is one of the rules, plus gentamicin. Gentamicin to speed up and to have a synergistic effect as well. Speed up the treatment and to have a synergistic effect. طيب, what if the patient, same scenario, but they're allergic to beta-lactams? Remove beta-lactams and have cefazolin, vancomycin in this case, because remember one of the rules, if the patient is beta-lactam allergic, cefazolin vancomycin, and gentamicin has a synergistic effect with vancomycin. Okay, I hope you're catching on to the rules and everything. Now we have if it's not community acquired or nosocomial, from hospital related, native valve, or before 12 months of prosthetic valve, what we would give in this case. So now it's a strong, we're expecting it to be a strong sort of species here. And here is before 12 months, so it's considered foreign. So from the rules, nosocomial NVE or less than 12 months PVE. We would give vancomycin from the rules. It's prosthetic valve before 12 months. So what do you expect us to give? We would give rifampicin. Rifampicin is very important in this case. Okay, plus gentamicin.
Okay, so change of settings. We'll be moving now to screen recording for the last segment. We're already done with prophylaxis. We're done with empirical treatment. And now we'll be moving to the last part, which is definitive or standard treatment. Okay? And before moving on to it and moving specifically to treatment for streptococci and staphylococci, we have some side notes that we want to mention, which are right here. Okay? So first of all, quick notes. Aminoglycosides plus cell wall inhibitors, they have a synergistic effect. Aminoglycosides like gentamicin. And for Enterococci facilis, this specific strain, to treat it in infective endocarditis, we would use ampicillin, ceftriaxone. Okay? So those are the side notes to mention. And now we'll be moving on to the main part of the standard treatment. So first of all, we'll start with streptococci. If the strain that the patient is infected with is fully susceptible to penicillin, then obviously we would use penicillin or amoxicillin or ceftriaxone. Here we're using or because we're already sure of the microorganism that the patient is infected with, so we won't have to use a lot of antibiotics like we did with the empirical treatment to cover everything. We already know the specific thing. And for this specific treatment, we would keep it for 4 weeks duration in native valve endocarditis and 6 weeks duration in prosthetic valve endocarditis. What if we want to speed it up a little for specifically the native valve endocarditis? If we want to speed the treatment, what would we do? Logically, from our rules, what is a medication or a drug that we can give that can speed it up? It is gentamicin. So we would have the same exact thing as above plus gentamicin. Okay? And if the patient is beta-lactam allergic, in this case, we would give them vancomycin or daptomycin as an alternative for vancomycin. And this follows the rule of vancomycin that we've also mentioned earlier. And lastly, for this, for streptococci, if the strain is partially or relatively resistant to penicillin, we would keep the same exact sort of treatment as here. However, we would just increase the dose. So if we're giving penicillin, we would increase the dose, or ampicillin, but increase the dose, and likewise with ceftriaxone. However, here we would also add gentamicin. And the rule that we have to also remember for gentamicin as a whole, generally speaking, is that we would usually give it for a maximum of 2 weeks due to its adverse effects. Okay, and now the last part, we'll be talking about staphylococci. So with staphylococci, if the patient has a strain that's fully susceptible to methicillin, we would give them, and this should ring a bell, it was one of the rules, fluxicillin. Okay? And we said earlier that fluxicillin is anti-staph. This is why we would give it in this case, because we know that the species is staphylococci. Okay? And if the strain, and by the way, for this one, for native valve endocarditis, we would have this treatment for 4 to 6 weeks. Okay? طيب, for this same case, if we have the species is methicillin resistant strain, okay, then what we would give? Obviously, in native valve endocarditis, we would give what? Vancomycin, follows our rule for vancomycin. And if the patient has a strain that's fully susceptible to methicillin, again, however, here the difference is there is a prosthetic valve endocarditis. We would keep the treatment for 6 weeks, and we would give, because again it's a staphylococci species, we would give fluoxetillin or ceftriaxone, and because this is a prosthetic valve, we would also add rifampicin, and we would add gentamicin. Okay? And if the patient here, if there was a methicillin resistant strain for prosthetic valve endocarditis, we would have obviously vancomycin as we know, rifampicin as we know, and gentamicin as we know. Okay? And remember here, the gentamicin isn't to necessarily increase the speed or decrease the duration of the treatment. Here it's for the synergistic effect. Yani for example, here it's for the synergistic effect with vancomycin. Makes the treatment better and stronger. Okay? So inshallah this was helpful, and thank you so much.